would like to invite the next speaker, Dr. Ravichandran Jagannathan.
So, the reason as to why I changed that one little word was, if you were talking about auditing and prevention, then we are talking about two different things, and at the end of the day, we are not going to go back home with any message. So this little word in instead of end will now see how does having a good audit mechanism will actually help us and share some experiences across the globe where auditing has helped in prevention of stillbirths. So this is where I come from, just slightly 2 kilometers north of Singapore, and I think we are somewhere here in the central of India. And this is my hometown, Johor Bahru. And of course, you all know that we have the youngest prime minister in the world now. So what is audit? Audit basically, by definition, is the healthcare process used by us health professionals to assess, evaluate, and to improve the way we look after our patients. And usually, these audit measures look at our current practice as defined by what we call maybe a gold standard. And this is a very important part in what we call in the clinical governance of anyone who is doing clinical work. So the key features of an audit would include, are we actually doing what we believe is the right thing and in the right way? And unlike research, which asks what we should be doing. So it's not what we should be doing, but rather looking at what we are doing. And audit can be used to evaluate various aspects of patient care. And of course, it's a very good look at how the outcome is if we adhere to the process that we have in place. So basically, it involves 6 steps, okay? You have to identify, say, it's a perinatal death or a stillbirth, get the information, analyze the results, look at possible recommendations, implement those, and see whether they work. So this is basically the cycle of how an audit should work. And if you look at the word prevention, by the Oxford Dictionary, the prevention means stopping something from happening or arising. So in this context of today's talk is preventing our fetuses from dying. And there are modifiable factors that we use. Sometimes we use the word preventable factors, meaning that we can prevent if we have taken another course of action, or we do a particular thing because we want to limit the opportunities for blame and present potentials for positive change in our practice. And this again, we look at the preventable factors and we can classify them as simple and complex. The simple is what you and I can initiate. The complex is where we may need our political masters to help us. So now look at the definition of stillbirth. There are many definitions running around. Okay? A fetal death or stillbirth is defined as a baby born with no signs of life after a given threshold. This threshold is what is very controversial. If you look at ICD-10, okay, which was developed decades ago, they said it is non-standard, gives birth weight as the first preference in the definition against gestational age. So what we have is, if you look at ICD-8, they define it as 1,000 grams. So any baby that is less than 1,000 grams will be considered, that has died in utero, will be a stillbirth. Okay? And then we have, of course, the various measurements like 35 centimeters or more. But what is interesting is that WHO at this moment uses 28 weeks as the definition for stillbirths. But in Malaysia now, we use 22 weeks or 500 grams. So if you know the gestational age, regardless of the weight, we use 22 weeks. But if you do not know the gestational age, then we use 500 grams as the cutoff. Because of this variation in the way we define stillbirths, sometimes the rates and the ratios will vary across the countries that we are looking at. Now, we all know about MDG, and we know that in MDG, we looked at mothers and the babies and the under 5 population. But of course, in 2015, MDG finished, and many of the countries, including Malaysia, did not meet much of the targets. So what we did was we have moved on to sustained development goals, which will go on till 2030. And here again, we are looking at reducing our maternal mortality ratios, as well as our perinatal and under 5 ratios, which of course will include our stillbirth rates as well. So if you look into the incidence of stillbirths globally, as in 2015, 2.6 million stillbirths occur yearly, okay, with more than 7,000 occurring on a daily basis. And majority of these deaths occur in developed countries. and 98% occur in low and middle income countries. Meaning to say that the developed countries somehow or other seem to be addressing the issues of stillbirth. And about 50% of stillbirths occur in the intrapartum period. So if you are in a country with low resource and if you have a significant stillbirth rate, then you would want to look at your intrapartum process as the first factor in trying to control your stillbirth rate rather than looking into your antepartum or pre-pregnancy. Okay? So intrapartum still rate varies, okay? And in the low income nations, it is almost in the region of 60%. Now the distribution is, of course, 3/4 of all stillbirths occurs in South Asia, which of course India is part of, and the sub-Saharan. And of this, 60% occurred in rural families. That means of this, 60% of the stillbirths occurred in the rural setting. Okay? And obviously, if you look at the rural setting, then we have issues with regards to access and accessibility. Okay? Again, when you look at access and accessibility, then of course looking after the pregnant mother during the intrapartum period is a big issue. And of course in the rural areas we may not have skilled birth attendants. Okay? And this is something that we need to realize. So although the stillbirth rate globally has declined between 20 to 2015, but it is not keeping in tandem with the decrease in the maternal mortality ratio. We are doing better in saving our mothers, not doing as well as we should, but we are doing better. But we are not doing as well as how we are saving our mothers if we look at how we are trying to save our babies. So if you look into the global distribution, you will find that Malaysia is not too bad, our rates are okay, but India and South Asia still are not doing too well. Okay? And if you look into the country variation, okay, if you look at it, the 10 countries that account for 66% of the world's stillbirths, number one on the list is India. Of course, the huge population is, of course, a risk factor by itself. But the fact that we have all these qualified obstetricians with us, and yet the stillbirth rate, we are still leading globally, it means maybe we are not looking at it the way we should. Okay? And if you look in terms of preterm birth, again, which contributes to the perinatal mortality ratio, again, you find that India, again, is leading. So obviously, there's a lot that we can do in order to prevent stillbirths. And in order for us to know what is it that we can do right and what is it that we are not doing right, we will need to audit. And of course, if you look at all these causes of stillbirth, it's not going to vary. It is something that you and I know. And if you look into the adoption of maternal and perinatal death notification, you will find that South Asia, from 2008 to 2014, we have hardly improved compared to other parts. That means there's still a lot of work that we can do. And this is definitely a neglected tragedy. 2.6 babies are dying even before they see the light of the day. Why is it so? Is that something that you and I can do? So if you are comparing this to the airline industry, okay, you'll be surprised. If these statistics were shown in any airline, none of us will travel by air. Most probably you'll either go on foot or may not even travel at all. But we are letting these horrifying statistics to exist. See, that means, you see, 830 mothers die during and following pregnancy and childbirth on a daily basis globally. 830. But there are 7,178 babies who are stillborn every day. And if you take a plane that has, say, 400 passengers, you divide that by 7,000, that means about 20 aircrafts are crashing every day with mothers and babies who will die. If even one plane crash, even that one chartered plane that crashed in Mumbai, I think 3 days ago, it made the headlines. Has any of this made the headlines? 20 planes of mothers and babies are crashing every day. We all are not seem to be bothered. Why? Because the statistics don't impact on us as the way we should. And this is a study that came out from our very own from India. And of course, the study says, the Lancet study itself says that India has the highest number of stillbirths. So I think it's very timely that we get our audit processes in shape so that we start looking at ourselves to see how we can improve. And I keep saying ourselves because I consider myself very much an Indian, although my passport may be Malaysian. So we have to make every baby count, okay? So in order to understand and appreciate the fact that every baby counts, we have to understand the burden. And I think Just in a couple of slides ago, we have understood the burden. But we must generate information. We all may be focused into reducing stillbirth, but if you and I do not know where to start, then we are not going to make a difference. And of course, we have to provide accountability, okay? Because once you make this decision and you have found that there is issues, then we must be accountable to make sure that we address these issues. So basically, there are 6 steps in auditing a death at any facility. Let it be a perinatal death, let it be a stillbirth, let it be a maternal death, it doesn't matter. It follows the same principles. The step 1 is to identify the cases for review. See, if you look at the stillbirth rate, it may be very much higher than maternal mortality. So you have to now consider on yourself in what you think is a preventable cause of the stillbirths. You see, if it is lethal congenital anomalies, you and I can't do anything about. But if it's, let's say, diabetes, connective tissue disease, this is something that we can do. But we have to identify which is the pressing problem. The second thing is collecting information. Now, collecting information is very important. Collecting information must be information that you need, not information that you would like to have. So this would inform a strategy where you don't want to overburden the data collector with too much of data, because not all the data is going to be useful, but data that is relevant for you to tackle the problem that you have identified. Then, of course, once you have identified the case, you have collected the information, you must have the expertise to analyze. Now, this analysis has to be done in a very independent way. I remember way back in 1990 when we started maternal mortality reviews, for the first 5 years, we couldn't analyze the data at all. Why? Because at that time, the number of obstetricians in the country were very few. And if we had analyzed and found out that it was due to the obstetricians' substandard care, then a lot of my teachers would have got very angry with me. So we waited either for them to retire or for nature to take its course, and then we analyzed. But of course, in stillbirth, I think we can be a little bit more proactive. Okay? Now, once you have identified, got the data, okay, analyzed it, then you must recommend solutions. Now, solutions cannot be things that are so big that it's going to take a decade or more to achieve. Look at small things that you can look at. Like in Malaysia now, our incidence of diabetes in pregnancy is hovering around 15 to 16%, which is very, very high. And until last year, modified oral glucose tolerance test was only done based on a very strict criteria. But from this year, it is now available to the entire obstetric population free of charge, because we showed clearly that stillbirth rates were high because of uncontrolled diabetes. So we had evidence. With evidence, we showed it to the ministry. So ministry said, how much more would you need? I said we needed 8 million more, and we got 8 million ringgit more to do a universal screening of diabetes in pregnancy. So this is how your data can and how you recommend solutions. Once you have a solution, you must implement it. It's no point having very nice solutions in books and booklets and presentations if it doesn't hit the ground. So you must see how to make it happen. And of course, once you have done it, don't rest on your laurels. Give a little bit of time for all these things to work, and then look back and see whether your interventions, your data has actually made a difference in looking after our population. Okay? So you must understand that the key in tackling the burden of neonatal and stillbirths is understanding primarily what is the cause. And the cause that you're looking at is something that you and I can influence. Okay? A vast majority of these deaths are preventable. Okay? We need good methods of analyzing this overall data so that we know how to make the changes happen. And of course, once you make these changes happen, you should be wise enough to accept feedback that this is something that you and I have been doing wrong. And how we practice in maternal mortality ratio, this is not trying to find fault. We are not going to point a finger at anyone and say, this is why the baby died. Although we like to do that, okay, but we should not do that. Share the blame and we will move forward. And that is why WHO has come up with this every baby count audit, which I think is available at the WHO website that you can easily access and modify it to your facility need. So these are the reported audit findings that we can get. It must be, if you have it in the local language, have it in the local language. Make it very easy to follow. Okay? Include standard sections. And what is important is, as you are doing this, always look at what you're practicing at your local level. Don't look at what NICE guidelines tell you. Don't look at what the RCOG guidelines or the Australian guidelines tell you. Look at what you are doing, and then only you will find where you can intervene and make a difference. So this is some of the data that has come out, and you'll find that even in the high-income nations, they're having, and UK surprisingly is having a problem with stillbirths. Although their numbers may not be very huge, but nevertheless, depending on the definitions, they still have a significant number of stillbirths. Okay? And they are looking at it very seriously. And the other thing that audits will tell us is to see how fast are we moving. So if you look into what SDG says and everything, and Rwanda is one country that you know which had a genocide incident not too long ago, but they are picking up the pieces and they're doing well. But the rate at which we are moving seems to be very slow. SDG will come to an end in the next 12 years. But if we move at the rate we are moving, it is going to take 160 years to look at any possible change. So I think it's timely that we re-look at our strategy. So this is basically what we are saying. Globally, everything seems to be coming down, except maybe the price of oil. But what is important is we need to realize that this is the rate at which we are progressing, which is not good enough. We have to accelerate it. And this is where I think all of us can play an integral part in assessing what is it that we are doing wrong, admit it that we are doing wrong, and change our practice. Okay? Now, it's also interesting to know that this data tells us how, with good data, with a good audit procedure, we can actually reduce stillbirth rates. So this is evidence to say that audits will actually play a significant role in reducing stillbirth rates, not to say that it also does in many other things. But it's very important to realize that all these things are some things that you and I can do something about. It is not something that is beyond us. We can detect syphilis, we can immunize our patients, we can manage hypertension, diabetes, and preeclampsia. We know how to plot growth charts, we know how to identify symmetrical and asymmetrical IUGRs, we know how to induce babies, we know when to induce, when not to induce. Like in Malaysia, based on our stillbirth statistics, all Indian patients will only be given 3 days post-dates. Okay? Whereas the Chinese and the Malay patients can be allowed 7 to 10 days post-dates. Why? We found that maybe for genetic reasons, Indians in Malaysia, based on gestational age, have the smallest placentas by size at the respective gestational age. I'm sure if you do a study here, it will be the same, but in here the entire population is Indian, so it may not really show. But we have 3 major races, Malays, Chinese, and Indians. So if you take a placenta at 40 weeks and you compare, we find that with no any other confounding factor, the Indian placenta seems to be smaller. Hence, our reserve is smaller. So trying to push them for 14 days as recommended by the NICE RCOG guidelines will end up with a very high stillbirth rate. So we have to modify practice. So this is basically how we can do that. So the key messages before I leave is that it compromises a condition that is preventable. Many of us don't take stillbirths seriously. The 5 priority actions that change the trend for stillbirths will have to be voiced in, and all of us must look at stillbirths as seriously as how we would want to look at the maternal mortality. Leadership is critical, extremely important, just like how Dr. Paili has done his work in Kerala. We need people who will look at stillbirths. And the one thing I like is in maternal mortality, there's this thing that comes out, this journal that comes out, Dead Women Talking. I find that very, very exciting because the title itself is very haunting. Maybe for stillbirth, it'll be Dead Babies Whispering, maybe something like that. Yeah. So stillbirth rate is a marker of quality care in pregnancy and childbirth. So do not think that it does not reflect on how you and I work. And of course, in doing all this, respectful and supportive care is, of course, needed. So in conclusion, each death reviewed has the potential to tell a story that could have been done differently for both the mother and child. There's a growing demand for information how to implement and scale up mortality of audits of stillbirths to improve quality. We need local champions, and the benefit of audit and feedback is greatly acknowledged, and I think it's high time we started this. Okay? Of course, as we are moving towards sustainable development goals, the journey is going to be crowded, the journey may be slow, but we have to keep moving forward. It's a shared responsibility that we all have to, can't get that later. Yeah, it's not a video, it's just audio. Okay, this is just a little poem by an anonymous person on stillbirth. Read along and reflect. Thank you very much.